Good morning, everyone. We are going to have a debate, probably a battle session. Cardiovascular disease is increasing in alarming numbers. It not only increases the morbidity, but also mortality in developing countries, including India. Atherosclerosis is a preventable disorder. Lipids and lipoproteins are associated with atherosclerosis in general and coronary atherosclerosis in particular. Out of all the lipids and the lipoproteins, it is LDL cholesterol that plays a very important role or a pivotal role or even a central role, not only in the initiation of atherosclerosis in the form of endothelial dysfunction, but also in the progression of atherosclerosis ending in clinical cardiovascular event, including acute coronary syndrome and sudden cardiac death. If you analyze the data in primary prevention trials and secondary prevention trials, and trials conducted in high-risk group, very high-risk group, you'll be surprised to see that in spite of the fact that we have lowered the LDL cholesterol, we still have a considerable increase in the number of people who are getting a cardiovascular risk. It ranges from 55 to 75% of the people are still at a higher level in spite of the fact that people had used effective lowering agent. Studies have clearly shown that LDL cholesterol plays an important role. The robust evidence is from the randomized control trials which had used HMG coenzyme A reductase inhibitor, statin. By reducing the LDL cholesterol, it is possible to get a good cardiovascular outcome benefit. That has been witnessed in many, many clinical trials. I think our views of tackling people with the lipid disorders, bringing down the LDL cholesterol, were almost in the process of what I can say, forward thinking. We were all trying to control the cholesterol with the data that was available way back 2003 or 2004 when the ATP3 guidelines were published. The last year when ACC guidelines started coming, people were wondering whether we were all wrong. Now they have simplified it, saying that we must have only 4 groups to treat. Are we in the right direction? Can we just blindly follow the ACC-AHA guidelines? And is it going to be applicable to Indians? Are we going to give high-dose statin or a moderate dose statin, upgrade it to high-dose statin for all our Indians? Is the one that we are going to probably implement in clinical practice? To start this debate, we have Rajiv Kovil, who is the Managing Director of Kovil's Diabetes Care Centers. He has 2 branches in Mumbai, faculty of numerous international and national seminars, conferences and workshops. He is an investigator for many international trials. He is also a faculty of the teaching diploma in diabetology students. To say it may not work for Indians, high-dose statin may not work for Indians. We have Dr. Gurpreet Singh with us. He has been working in SPS Apollo Hospital, Ludhiana, since 2005. He is a graduate of Government Medical College, Patiala. He completed residency in internal medicine from the Georgetown University program at Washington. He also completed fellowship of endocrinology at UMDNG, Robert Wood Johnson Medical School in New Burskin, New Jersey. He is a diplomat of the American Board of Internal Medicine as well as endocrinology, diabetes and metabolism. He is an active member of various medical associations. Let me now request Dr. Rajiv Kovil to say that high dose or up statins and forget, yes, it will work for Indians.
Thank you, Chairperson. Thank you so much for that warm introduction. Whether statins work for Indians and whether we need to look at lipid profiles before we can kind of start statins on Indian, we need to understand that today we are facing an epidemic of cardiovascular disease in our country. And gone are the days when we were treating only cholera, typhoid, and malaria. We are now, there's something wrong with the monitor. Okay. We're going to treat more of NCDs in our population, and the NCDs are going to be cardiovascular disease, diabetes, COPD, and cancer. And in 2004, India spent almost out of pocket 3.3% of India's GDP, which is 4 times the total spent by any government anywhere in the world. And almost 80% of these NCDs kind of come from developing countries. And we need to have a public health care policy which prevents NCDs. And among all the NCDs, coronary artery disease is the most common NCD in our country. And it's pretty unfortunate that next year we would have probably 2 million deaths because of coronary artery disease, of which 40% would be in patients less than 40 years of age. So actually it's the metabolic abnormalities that we Indians carry which drives this twin epidemic of cardiovascular disease and type 2 diabetes. So I think we are facing an explosion of premature heart disease, and I don't think we are equipped enough socially, medically, economically to handle this epidemic. And there are a lot of articles published on this kind of epidemic in India. The economic impact is huge, as much as 4 to 10% of our GDP. So we are losing people younger, we are losing money also. The risk factors continues to remain the same for CAD. The prevalence of CAD from a poorer state like Orissa is as high as 10%, which clearly suggests that this particular disorder is pan-India. It's rural, urban, semi-urban, it's across pan-India. Interheart study, one of the most largest study to find out the risk factors, told us 9 potentially modifiable risk factors account for almost 90% of the population attributable risk. What it showed us that Indians have the lowest HDL and the highest ApoB-ApoA1 ratio. These two lipid profiles, these two lipid parameters are the highest predictors for coronary artery disease across the globe. So we are a very, very high risk population. Again, the effect of the risk factors was very striking in young men. As we know, 40% in India will die of less than 40 years of age. And these are premature heart disease, which is preventable. And globally, practically no one in an urban population has a level of dyslipidemia that avoids an increased risk of heart disease. So we all know that death is inevitable, but premature death is not. And Indians qualify as a very high risk purely because 10 to 15% of our population have type 2 diabetes, maybe 8 to 10% have dyslipidemia, 30 to 40% carry the metabolic syndrome, 70% may have high homocysteine, 40% may have lipoprotein small a. So we are a very, very high risk population. And what should be an intervention? An intervention should be a low-cost intervention which makes a clinically significant change in public health. Statin is the foundation therapy in preventive cardiology, and the robustness of evidence which statins have in preventive cardiology is unmatched in any other medications. So statins for every Indian is a must, and it makes more sense where you have a very high risk of events. As you can see in the developed countries, the CAD rates are going down, and in a developing country like India, this kind of an intervention will make a lot of difference. So primary prevention comes first, and why we should be using statin, as I said, there are a lot of proof of concept primary prevention studies. The one in the white are the ones of primary prevention. The first one being the Voskov, which told us almost 7,000 men with moderate hypercholesterolemia were randomized to pravastatin, and there was a 31% relative risk reduction over a period of 5 years. AFCAPS told us almost 6,000 patients with an LDL cholesterol on lovastatin had almost 37% relative risk reduction over a period of 5 years. ASCOT LLA, the lipid-lowering arm of a hypertension trial, was stopped midway because of the benefit which patients received on atorvastatin. There was a 36% relative risk reduction. And these hypertensive patients also had 3 other cardiovascular risk factors, like we Indians have. So the CTT collaborators, which came in 2012, told us that 1 millimole reduction in LDL cholesterol caused a 26% reduction in cardiovascular events and almost a 10 to 15% reduction in all-cause mortality. So we have a lot of primary prevention studies which tells us that primary prevention is the way of treating a high-risk population. And this updated 2013 Cochrane review, which came in last year, clearly removed the cobwebs in our mind that probably a long-term statin therapy may help or may not. It told us that it caused a significant reduction in major adverse cardiovascular events, in the need for coronary artery revascularization procedures, as well as further events. And this confirmed our things that probably we need to give statins much, much earlier. Even in this updated review, the most important thing was the benefit was all across, whether age, sex, and even in patients who had a very, very low risk of cardiovascular disease, a low risk as low as less than 1% also derived the same benefit. The Jupiter trial, which had almost 17,000 patients, was stopped in 19 months because of the 44% reduction in the primary endpoint of cardiovascular death. In the Jupiter trial, there was a 20% reduction in all-cause mortality also. So there's a lot of evidence gathering up that probably we need to have statins at primary prevention, and we should be treating patients, not the lipid profile. And there's a lot of thought that probably these statins do not work in Indian, and they work only in the Caucasian population, but there are a lot of data showing that it also works in ethnic groups like Indians, and Indians should be given a statin. Whether high dose or low dose is something which can debate in another session. The most important thing is that Indians also respond to lower dose of statin, as this study suggests, and it's comparable to Caucasians. So the most important thing is that we need to give statins for most adult Indians because they're very, very high risk for, for coronary artery disease. The ACC-AHA guidelines also tell us that primary prevention should be there in patients with more than 21 years of age with any risk factor. Most Indians, 80% of Indians with the kind of lipoprotein, small a, homocysteine, metabolic syndrome, type 2 diabetes, and CKD are high-risk individuals. And one needs to understand that coronary artery disease somehow has a lot of liking for Indians, and at the same level of cholesterol, Indians are more prone to develop coronary artery disease as compared to Caucasians. This was a study published in 2005, which estimated that a cholesterol value of 108 milligram per DL has to be added to Indians to compensate for the underestimation of CAD risk calculated by the Framingham risk score. So for example, if an Indian has a total cholesterol 192, is similar to a European with a total cholesterol of 300. So would you not treat an Indian with a total cholesterol of 192 if this is the comparison? And this is the Indo-US summit which came out last year, which told us that low-risk Indians or Indians without CKD and diabetes also need to have an LDL cholesterol below 130, an LDL cholesterol below 100, a non-HDL below 130, lipoprotein small a below 20, triglycerides below 500. And what they hypothesize is that if we implement these guidelines, we could almost reduce 50% of cardiovascular disease in the next 25 years. Apart from all these effects on the cardiovascular system, we also know atherosclerosis is an inflammatory disorder. And statins have a lot of anti-inflammatory effects and also has a lot of antioxidant effects. And there are a lot of pleiotropic benefits of statins, which I'm not going into deep because of the shortage of time. We need to understand in the cardiac care cycle of India that there are a lot of stakeholders. And as healthcare professionals, what we can do is educate and probably give medication. But there are a lot of stakeholders, and there should be a kind of synergy among all stakeholders for this public health issue problem. As in my conclusions, I would say that previous arguments that statins do not reduce total mortality and that the benefits are limited to high-risk individuals are no longer valid. Benefits of statin therapy far outweigh any possible serious side effects, even in people at very low risk of CVD events. In primary prevention, statin therapy prevents between 1,200 to 28,400 CVD events. Due to the non-lipid lowering pleiotropic benefits, therapeutic benefit has been observed in non-CVD events also, and in CVDs like heart failure, arrhythmias, valvular disease, and hypertension. The risk of new onset diabetes is limited to those with known risk factors for diabetes, and the magnitude of the risk is only half of that of diuretics and beta blockers. CVD risk reduction is 50 times larger with statins, even among those who develop new onset diabetes. Excess risk of rhabdomyolysis with statins is 20, and fatal rhabdomyolysis is 2 per million person years. There is no correlation between magnitude of LDL cholesterol lowering and serious muscle or liver toxicity. This is in sharp contrast to the use of statins to the use of aspirin in primary prevention, where the net harm outweighs the benefit in many people, especially if they are already on a statin. Lowering LDL early in life is substantially more effective in reducing CAD risk than the current practice of lowering LDL cholesterol later in life when subclinical atherosclerosis is already present. Public health strategy that focuses on prolonged sustained reduction in LDL cholesterol beginning very early in life could potentially reduce the global burden of CAD, especially in India. While recommendations and guidelines are generally lacking, ongoing and future randomized placebo-controlled trials are aimed at further delineating their potential use in non-hyperlipidemic indications. It's time to expand the dictum that from lower the better to lower and earlier the better. I'm sure if we do this, we could reduce the CVD by approximately 50%, and 50% of our interventional cardiologists will be out of work. Thank you so much.
Thank you, Dr. Rajiv Kovil. Now let me request Dr. Gurpreet Singh to oppose him.
Thank you, Chairperson. Let me start by talking about what is different from the new guidelines where we are recommending statins to more and more patients compared to the old approach. Now, part of the story is based on an LDL step approach in the 2004 guidelines compared to what we have is the new guidelines. And the key difference between the two guidelines, the old ones and the new ones, is that it has been noted that most of the randomized controlled trials with statins done mostly by pharmaceutical companies were based on a fixed dose of statins, not on a treat to target approach. So the majority of trials would say you would give a placebo or, for example, a atorvastatin at a fixed dose, no matter what the LDL reduction would be. So they are basically saying, how can we label if LDL target when most of the trials, the way they were done was based on a fixed dose. And this is the reason, one of the reasons they give for making those changes. And for example, in the old guidelines, you have less than 100 LDL target for people with coronary artery disease pre-existing and diabetes, compared to the new guidelines where if you have coronary artery disease, then you would need to be on high dose, high intensity statins from the beginning, irrespective of what your starting LDL cholesterol is. So I'm not debating whether patients with pre-existing coronary artery disease should not or be on statins. They all must be, we all agree. The question is not of secondary prevention, the question is about primary prevention. So part of the difference in the new guidelines is also based on the risk scores. So people who have already had a heart attack, which is secondary prevention, well, they would certainly need to be on statins. Now the question is, for people with primary prevention, there have been various methodologies to estimate the risk score. What is the risk for a normal individual who comes to you for a routine checkup? And at what level would you want to put him on a statin or not? And that is the key question. And the question here is, what is his risk of getting a heart attack many years later? And therefore that we need risk engines, risk scores. And the new guidelines are using a new risk score where they're saying anybody with more than 7.5% risk of 10 years heart attack would need to be on moderate or high intensity statins, irrespective of what their LDL cholesterol is. And whereas the old guidelines would say less than 10%, maybe only if their LDL is above 130. So we are differentiating here that if you have more than 7.5% risk, give everybody a high dose or moderate dose statin. Now LDL is a very, very juicy target for the downstream atherosclerotic process, and therefore it becomes logical in the mind of pharmacological intervention. But we must understand pharmacology is a knife, just like a knife in the hands of a surgeon. So we must incise where the need is and not put our hands back where we don't need to incise. And this is, once the plaque ruptures, that is secondary prevention. And primary prevention happens from maybe in vitro going forwards, and it's a gradual process. So mainly if you wanted to slow down the atherosclerotic process, where do you start in primary prevention? And how robust is the data for this hypothesis of LDL lowering for people who are otherwise healthy? That is the question. Now, even before we go there, this was a very interesting study done looking at developing versus developed nations, and what they found was even people who have had a stroke or a heart attack, less than 5% were on statins, either short-term or long-term. So the compliance is horribly poor, both in terms of our physicians' practice as well as the patient's compliance. So on one hand, people with pre-existing coronary artery disease who need to be all on statin, I agree. and they are only less than 5%. And we are saying normal healthy people sitting in this room, we should all be on statins. Is that our right strategy for a poor developing nation? Is that the right way of looking at it, is my question. So differentiating secondary and primary prevention now, the trials which we had said were not mostly treat to target, but for example, in the 4S, you would give a fixed dose and look at what was the reduction. Now, the reduction in event rate is always very high. If you have one heart attack, you would most likely have another heart attack sometimes in your lifetime. Therefore, since the pre-existing risk of heart disease or another event is so high, so therefore reduction, even small reductions make dramatic changes in event rates. Whereas in primary prevention, people have much lower 5 to 10%, for example, risk. So how would the intervention help them? Well, in the terms of statisticians being used by pharma companies would say there is for example, the risk from 7.5 to 3 would be a 50% reduction. So we all seem very impressed, that's a 50% reduction. But in absolute numbers, it isn't much. So we have to realize where we incise in what primary prevention, what are those patients who we would attack. Now, lipid modification should start very early, which is lifestyle modification, and which we always ignore in our children in a young country population. They're all not exercising, getting obese, and we forget that is the primary prevention strategy we must adopt. And we are ignoring that. So are we going to give people in the age of 20s a statin? How long? And does giving people a statin just with a normal healthy person, won't that discourage them to use their lifestyle modifications better? Yes. Well, a data just presented, published in the JAMA April 2014 had suggested gluttony in the time of statins, that people who are non-users have, for example, a 80-gram fat intake over a period of 10 years from 2000 to 2010, whereas people who were on statins 10 years ago used to take things seriously. My God, my doctor put me on a statin, now I must control my diet. And they used to improve their diet. And now since everybody is on a statin, the majority, the fat intake is actually going higher compared to non-statin users. So we are getting people complacent and not ignoring the fact that they must control their lifestyles. And what we have is in the European guidelines in 2012 is looking at what is the benefit of treatment versus what is the benefit of risk factor in a reduction in 10 years over mortality. And what we see is attribution to treatments such as statins is only half of what is attributed to risk factor modification in the Western world by media, by government processes of how you improve people's lifestyle. And that is equally important to what you do in a pharmaceutical way. So cardiometabolic risk major drivers, well, you could have smoking as a risk factor, physical inactivity, unhealthy eating. Would we put all of them on statins for risk reduction? Of course not. What about hypertension? Would we use an antihypertensive? Of course. So inflammation, hypercoagulation, increased glucose, and we are focusing on LDL because that's a juicy downstream target. And then we have increased ApoB1, as Dr. Kovil had shown in his slides, and low HDL and increased triglycerides. And this is the atherogenic Indian dyslipidemia. And isn't this sound similar to what we were doing in the glucocentric approach of diabetes, where we would say, no matter how you lower the glucose, it doesn't matter. So no matter how you lower the LDL at the downstream target, does it matter? Well, it matters in physiology, and nature always teaches us a lesson. It doesn't matter that if it is hyperglycemia, how you beget normal glycemia is also important. So there are striking similarities. We probably will learn over the years with statins that we were overutilizing it, just like we were overutilizing sulfonylureas. So comparative effectiveness of drugs is 11% reduction versus 18% reduction with exercise versus statins. Well, these are similar ballpark numbers. For example, a case of a friend of mine, an engineer, chain smoker, hypertensive, with a fasting glucose of 104, which he is pre-diabetic, has a total cholesterol 156, LDL 90, HDL 29. So what should my prescription be for him to stop smoking? Give him antihypertensives, or just a personal effort to convince him of a lifestyle change? No, none of the above. According to the new guidelines and according to what we are being told today, well, I should give him 40 milligrams of atorvastatin. That is the right answer, even if I lose him as a friend. Would I do that? Of course not. So you put a risk calculator here for the new guidelines. This is what they're asking us to do. Everybody should have one in their office. or in their mobile. And if you put all the data together, it says for this patient, 48-year-old, other ethnicity Asian, moderate to high statin is recommended. So there is the embarrassment for the pharma industry, and BMJ says, and there are various hue and cry that major panelists on the new guidelines were, had ties with the pharma industry. And I think we need to not put labels on people, but we must understand that we cannot put 40% of our population on statins for primary prevention where there is other ways of looking at it. So numbers need to treat as a more important, a better way of looking at it. So if you have 140 healthy people in this room, and I say, if I ask them to pay 6,000 a year for a statin, and it's for primary prevention, only one of us 140 would be prevented from a cardiovascular event, and 139 would spend 6,200 per year and would maybe get muscle pains and slow down our exercise capacity because of the pains, and even risk getting diabetes. And what if I told you just exercising, eat better, being personal for encouraging better behavior in our patients would be a better strategy? What is the answer? Just like, if he was not my good friend, would I not advise him all of that sincerely? Certainly I should. And for the dearth of time, I'm going to make it much shorter. The risk calculators used are overestimating risk in the new guidelines. This is based on softer or outcomes of coronary revascularization in the new data. And what it means is, if I come to the emergency for chest pain and I am, I am forced to get an angiography and somebody puts a stent, that becomes a primary endpoint in the 2013 Cochrane analysis, and that is the reason why we are overestimating the events, the endpoints in the primary prevention strategy. So cardiovascular disease in South Asians is certainly different, and none of these risk calculators is validated in our Indian populations. Indians, whether they reside in any country in these blue graphs, die much more than the other population. Now, genetic predisposition and excess intra-abdominal fat is certainly an issue. And we have much lower total cholesterol, much higher triglycerides, low HDL, and still we die more. And the question is, aggressive LDL reduction does not eliminate coronary disease events. Can I get 2 more minutes? Is that possible? Okay, I just do it in 2 minutes. Okay, so in the best trials, you get 35% reduction in coronary events. So what about the rest of the 65%? What is the reason for the rest of the cardiovascular risk reduction that has not been achieved in these trials? And maybe fibrates are the answer and triglycerides are the answer. And if you look at subset analysis of these fibrate trials, you will see compared to placebo, people who have the atherogenic dyslipidemia, the higher the triglycerides, lower the HDL, the more the benefit in cardiovascular disease protection. And and this is the problem with the CORD trial is, in that trial, what they showed was that adding fibrates to statins were not useful. And the reason why this was that people with normal HDL, normal triglycerides were also put on fibrates. So you're diluting the main question that should people with central obesity, metabolics certainly be focused and put on fibrates as an additional risk reduction? Well, that is certainly the true answer. And the predictors of new onset diabetes in patients treated with atorvastatin certainly depend on whether they have the metabolic syndrome pictures. And what about diabetes? Certainly the higher dose of statins you give, the more is the risk of diabetes. And myopathy is certainly lesser reflected in these trials. And one of the reasons is that people are excluded pre-randomization, that those who have muscle pains will not get a statin in this trial. So most statins will show that there's less myopathy, which is much more actually. And at the end of the session, I would say, what is the prescription cost benefit ratio? And the answer to that is, for 3.5 rupees a day of a statin, you would end up spending 10 lakh rupees for preventing 1 death in 5 years and 5 lakhs for preventing 1 CV event. And if you look at, if you prescribe a generic statin, if I prescribe another usual best-selling statin, I would spend 25 lakhs to prevent 1 heart attack and 50 lakhs to prevent 1 death. Would it be useful for a country like ours? Certainly not. So we must actually say, instead, let's stop, look, and go and focus based on risk profiles rather than giving statin to everyone. Thank you. Thank you for listening.
We'll have a quick rebuttal by both the speakers. Each 1 minute is allotted now.
By using statins, I never meant that the other interventions do not have a role. Multifactorial intervention, quitting smoking, walking, exercising, like we prescribe in diabetes, only writing a drug is not enough. Compliance should not be a scientific debate, as doctor, the secondary prevention patients are not compliant. That's a different issue than what our strategy should be. The optimum LDL level is 40. And there is data that for every 1%, 1 milligram rise, there is a 1% change. So at an LDL of 70, you are almost at a 30% higher risk as compared to an LDL of 40. There is also data that when the LDL is 60, the plaque starts accumulating cholesterol. So we need to understand that we are facing a public health problem here, and we need to have a public health strategy in place. And most importantly, Indians are at least 5 to 6 times at higher risk for CADS compared to Europeans. We know that for a 10 millimeter rise of blood pressure, there's a 3 times higher risk for stroke in blacks as compared to white. The International Society for Hypertension has said that the blacks should be at a much lower blood pressure as compared to whites. So why can't we have the same extrapolation in terms of cholesterol, that Indians should be at much, much lower cholesterol for primary prevention? Thank you so much.
One important point I would like to mention here is, for most trials, if somebody gets enrolled in a trial, he's going to get calls every week from an educator. They're going to get lifestyle education. Now, whenever we look at randomized control trials, which are the gold standards, we must realize whatever they did for their patients, are we doing in our clinics? And that is my key critical question. Same thing with UKPDS. In diabetes, we'll say this much glucose reduction is important, but are we doing all of that? I think at least in my part of the country, we aren't. For most of our patients, we aren't checking if they are compliant. No nurse is calling them every week, giving them free statins, and asking them, are you having muscle pains, myopathy? Nobody is doing that. So now companies are actually trying to improve the compliance with statins by having SMSs, this and that is certainly true for secondary prevention after a coronary event. For primary prevention, I certainly think risk scores are the way to go, that you have to not just look at the risk of getting diabetes, but also the pre-existing LDL level. So the old guidelines certainly were smart in saying if you have LDL of 64, and you are at a moderate risk, then you must weigh what is the cost to benefit. So that is not true for the Statin Up strategy. So I think at the end of the day, what we really need to do is, whenever we look at interpretation of randomized controlled trials in our daily practice, we must realize if you replicate those conditions only when we're going to get there. And I think the prime key importance here is to get there for secondary prevention, not for primary prevention. That is my argument.
Now, what I will do now, straight away, not for voting, let me request some of you to ask questions. You can ask questions to the first speaker, and then try to interact with him. Then we will move on to the second speaker, try to interact with him. Then we will have a voting. At the end of that, probably I will have to show some slides to impress you what is the best. Okay?
Okay. Score where you would like to start on a statin. You say that score is more than 7.5. If I have a score of 7.7 or 7.6, should I start on a statin? These are the things.
You would like to respond?
I think on the similar lines, can I just put a rider to Dr. Rangarajan's question? To Rajiv Kovil. Sorry to make it a bit more personalized. If it's your brother who's 28 years old with a LDL-C of 131 and a triglyceride of 205 and obesity, would you start him on a statin or not?
I would start him on a statin. And I'm on a statin for primary prevention.
Sir, I'm a primary care physician, and I want to make sure that I go with the right kind of message. If I have to, I think Dr. Narasingan will be the right person to finally moderate and tell us what we are supposed to go home with. The question, I was quite impressed with Dr. Singh's presentation. So he said that I don't just look at LDL, but I look at risk scores. And I titrate risk scores with LDL levels and then decide whether I need to do statin. Is that the message I'm supposed to know? Yes. Point one. And thing is, okay, the Indian profile is more of hypertriglyceridemia, and therefore, are we just looking at LDL and not really handling triglycerides? and therefore emphasizing too much on statin and not on fibrates? Is that another thing that I'm supposed to know? Is my second question. And the other thing is, of course, don't risk compliant. You're given statin and everything is done. Look at lifestyle first and tell them that this statin is going to work. This drug is going to work only with lifestyle. If no lifestyle, this is not going to work. Is that what I'm supposed to go home with? Because I am a primary care physician and I think we stand in front line when it comes to prevention.
Would you like to respond?
I think you summed it up all accurately. Even the old guidelines tell us that people who have pre-existing coronary artery disease certainly need to be on an LDL of less than 70 or less than 100 based on very high and high risk. And same thing with the diabetes is less than 100. So you realize that even the old guidelines are asking you to put up, start entering those data into a Framingham risk score calculator. And I have a problem with all of this. And the problem with all of this is in a country where we have very busy OPDs and we have to handle a lot of patients, how often are we all opening up a computer and phone and putting up a risk calculator? But on the other hand, if I wanted to do it mentally all and memorize the risk scores, I cannot do those tables, memorize them. So I think at the end of the day, we must have a strategy where at least you have maybe manual risk calculators given to doctors by pharma companies. Maybe this is a message for them to help at least give back of what they get from the patients in terms of statin prescriptions, that we have an easy method of assessing the cardiovascular risk. Now the new guidelines are saying 7.5 is your question, and the old guidelines are saying less than 10%, more than less than 10%, 10 to 20. So they're categorizing based on the risk. At the same time, they're taking in account what their LDL target should be. So that excludes people who have 7.7 risk with an LDL of 78 naturally, with his patient's father living to be 85 and still healthy. So we are excluding those people who have normal LDL and have a normal or moderate risks. So I think you have to take both in picture. So, yeah. Yes, right.
Yeah.
Number two, we are not addressing non-HDL cholesterol.
Exactly, that's what I said in my talk about residual risk.
I think we are running out of time. We'll have lost it.
Because we have different risk scorings, like Framingham risk scoring, Cleveland, and there are lots of difference of opinion between the scoring, and the accounts taken in the risk scoring itself is dependent on lots of factors. So, is there any strong risk scoring in Indian patients? Is there anything?
No, that's what my last slide was.
When it is not there, how are we going to cope up? The second question is that, one important, what you told his point is, when they make a primary prevention and on the trials, then a 35% reduction they claim. But what about other 60% about? In India, when you take a population statistics, but it will run crores. And I think it's a methodical ways to spend money on statins, on primary prevention.
I'm on your side, not
The last one, please. Last one.
You see, there's a comment on that with Gurpreet that
One minute, he's talking now, please.
the atherosclerotic cardiovascular risk score, in my opinion, I'm from Delhi, Gangaram Hospital, and I found, and I did it on few patients recently, it grossly underscores. That is what we found. This is one. Number two, my issues are there that many patients in India, all the guidelines says use high dose statin. We found in Indian population, modest dose statin, like 20 milligram of rosuvastatin or 40 of atorva is good enough to achieve the goals, whatever used to be there in the past strategies. The advantage is that the new onset of diabetes, which we know it is not very important but it is only short term which we have got. But the new onset of diabetes, long term implication we don't know at the moment. So what we found, the new onset diabetes is again dependent on the dose and the duration. So that is very important. So if you have a modest dose, it has 2-3 advantages. We reduce the new onset of diabetes because our population is prone for new onset of diabetes based on the metabolic syndrome and high risk. Number second, if you want to add fenofibrate to this group of patients to take care of the residual risk, as we have seen in field study, then in that situation, the risk of side effects of the statin will be also reduced. And finally, I think that we are working now in a Cardiology Society of India on looking on our own guidelines, because the atherosclerotic guidelines grossly underscores our population. I think that is what probably needs in future. We are going for that, looking for our own guidelines to be validated.
Thank you,
from
Dr.
the-
Sani. I would say that y'all should, the Cardiology Society should also name Indians as CHD risk equivalent then, you know.
Yes, maybe, but not diabetes. As you say, diabetes is CSD risk equivalent. It is not only after 10 years.
We are running out of time.
10:02. 10:02.
Sir, we are running
Project
out
it,
of
please.
time.
Yeah, yeah. See,
Give the verdict, sir.
yeah.
Hello, I think
Yeah,
recently, a
10:02.
month ago,
10:02.
BBC had reported the statin has no role in primary prevention of any cardiac illness and arteriosclerosis. Arteriosclerosis is a continuous process from the day one till to your life. This is a continuous process.
Exactly.
So when you give statin as a primary prevention, it does more harm rather than goodness. So myositis, even it produces diabetes and all. So as primary prevention, statin has no role. Statin has a role in secondary prevention, that too in short period, particularly for myocardial infarction and stroke, from 6 months to 3 years. Then later on, we have to stop it, according to this BBC's latest report a month ago. So what is your comment?
I think a lot of things have been discussed by the speaker are intended only for that population, Caucasians. It is not intended for our country to get implemented in our clinical practice, number one. We have not been using even Framingham score because it's not appropriate. And the recently published scoring system in the United Kingdom, which was published in the form of nice guidelines, is called Q-RISK-2 score, seems to be very, very appropriate. And it has been actually published, and people in the United Kingdom have been requested to follow this score for their clinical practice. And it started from the month of March 2014. So when you look at the ACC-AHA calculator, number of criticism, number of papers have been published subsequently in New England Journal of Medicine saying that this scoring system either underestimates or overestimates. The one point that I would like to tell you is that 240 cholesterol, the blood pressure was 150 systolic, in spite of the people taking blood pressure treatment, and this fellow is seeking advice, non-smoker, non-diabetic. The risk score comes to us only 2.5%. He is not eligible for statin therapy. How can you say a patient with an established hypertension who has been on drug and still the blood pressure is systolic 150 and his cholesterol is about 230 or 240, how can you leave him? So you have to start him on statin. So there is underestimation as well as overestimation by using the ACC-AHA guideline developers calculated method. That's number one. Number two is the prevention. You need to concentrate on primary prevention, particularly the therapeutic lifestyle changes have been insisted by Dr. Gurpreet Singh. You need to. It should not be a lip service all the time. Whenever the patient comes to your chamber, you need to talk to them in detail about the dietary modification, about the exercise, about the other therapeutic lifestyle change, including the smoking cessation. A comprehensive approach in the lifestyle modification has to be done by you in your clinic as and when the patient seeks advice. That will go a long way. But most of the patients who are given this sort of advice are not trying to follow. Many of them come back and tell you that they did not find time to go through exercises or dietary pattern, these things. There's so many explanations. But people who are at a high risk, very high risk, there is no question, you need to put them on statin. People who are having an intermediate risk, for example, a patient with a family history of coronary artery disease, a patient with a severe hypercholesterolemia, or a patient with a diabetes type 1, type 2, or patients who have a problem of hypertension or a smoking history, I think you need to put them on statin. That's very, very important. Above the age of 20 years, if there is a strong family history or a familial hyperlipidemia, you need to put them on statin, very important. But the problem of residual risk, what has been raised, has to be accepted. You need to concentrate on that issue. Many of us facing this problem after the reduction of LDL cholesterol, you have about 55 to 70% of them are still having a high risk of developing the coronary artery disease. You need to concentrate on non-HDL, which was repeatedly emphasized and re-emphasized by the ATP3 guidelines right from 2003, which we were not following. Ladies and gentlemen, recently, about 2 months back, National Lipid Association in the United States has published a recommendation, a draft, which includes non-HDL as a first priority, The second one is LDL. And the second criteria, the second target will be ApoB. The third one is the usual insulin resistant syndrome therapeutic lifestyle changes. I think that recommendation seems to be good. In fact, I have a lot of slides because the speakers had taken a lot of time and your interaction was also taking a lot of time, and I've been compelled by the organizers that I should finish it on time. So ladies and gentlemen, both of them did a wonderful job. You did an excellent job. You did a wonderful job. Both of them have to be given good applause from your end. So, thank you very much, Dr. Krishna Shastradri. He put a lot of rules saying that I should also focus some slides. In fact, I was not very keen, but he wanted me to do that. In spite of the fact that they prepared slides, I'm not in a position to do that. Please go back and try to concentrate on NLA recommendation by the National Lipid Association, for where I'm also a member. And if you can just go through that, it almost fits in very well with our approach, our aim in treating lipid disorders. Thank you very much, ladies and gentlemen.